Hi students, so let's start with a new topic. So the topic for the day is anxiety disorders. It's a very interesting topic. So what is anxiety? Anxiety literally means fear for no adequate reason or an anticipation of for future threats. Let's now quickly go through how anxiety affects our performance. Yes, for students, it's very important, right? So this curve is known as Eric-Dodson curve. So what does this depicts? So here, y-axis, we have the anxiety, the performance level, and in the x-axis, you have your anxiety levels. So it states that when your anxiety is optimal, your performance becomes optimal. So that is, there should be an adequate anxiety for your best performance. Yes, for either of the sides. So if you fall in either of these sides, that is if you are not too anxious or if you are over anxious, either of these sides, your performance drastically goes down. Look, your performance drastically goes down. Okay, so when your anxiety increases, you have impaired performance. Yes, I wanted to convey one thing. Yes, it's okay to get anxious. Okay, but it should be within our desired limit, right? So let's quickly come to our topic. So yes, anxiety is a normal emotion, right? Under it comes under basically the autonomic arousal where we have our fight or flight systems activated. So yes, but there are some situations where this anxiety is maladaptive because it affects our day-to-day activities due to our increased anxiety. So then if it affects our occupational social functions, then it becomes a disorder, right? So coming to our topic, anxiety. So in psychiatry, if you take, there are two kinds of disorders. One is neurotic disorders and other is psychotic disorders. So what is the exact difference of neurosis and psychosis? So like here if you take, in neurosis, anxiety spectrum is under neurotic spectrum. So neurosis, the patient will have preserved judgment, insight and the reality, touch with reality and delusions and hallucinations. Okay, the patient will have touch with reality and there will be no delusions and hallucinations. So what does this judgment and insight means? Judgment and insight means if I have a disorder, like I can say I have a stomach pain, I know that I am having a disorder, I wanted to consult a physician. So that means you are aware of what you have. This is known as insight and you decide based upon what you have and you go to a doctor. That is judgment, taking a decision, right? That is judgment. Okay, so this is basically neurosis. In neurosis, both judgment and insight is present. But in psychosis, both of these, judgment, insight and touch with reality is absent because the patient will have delusions and hallucinations. Also, the examples of neurosis. What are the examples of neurosis? Yes, these are depression, anxiety. Okay, the old name for anxiety disorders was anxiety neurosis. Then the examples for psychotic disorder is, the prototype is schizophrenia. And very important topic, okay, of anxiety. Let's go to the classification. So the classification of anxiety disorders is itself a short note. So just according to the textbooks, anxiety disorders are classified as panic disorders, specific phobia, social anxiety disorder and generalized anxiety disorder. There are four things: panic, specific phobia, social anxiety and generalized anxiety disorders. Okay, and one important thing, if you look at this picture, all this anxiety, it is a spectrum of disorders which share common clinical features. Okay, which share lot of common clinical features. All these things which I have told, like generalized anxiety disorders, panic disorders, specific phobia, right? So here you should remember, like in anxiety disorders, the important features are arousal, autonomic arousal. Okay, autonomic arousal with sleep disturbances, with decreased attention and concentration and fatigability, right? And fatigability. So coming to these symptoms I told you, both these anxiety symptoms and will share a common features. So one important things you should remember is that what are the parts that is affected in our brain. Please note friends, two pathways or two circuits that you should remember is that the response of fear is concerned with amygdala. Okay, the response of fear is concerned with amygdala and its centered circuits, and worry is kind of apprehension and expectations and obsessions, right? So this worry is controlled by corticostriatothalamic tracts, tract, which is abbreviated as CSTC tracts. Okay, coming to neurotransmitters in anxiety. Yes, neurotransmitters in anxiety is very important. So definitely friends, I have given like there is autonomic arousal. I told initially the patient will be having fear, in secondary to that flight responses. So definitely which neurotransmitters is increased? It is the noradrenergic hyperactivity, your norepinephrine, right? So there is some serotonergic dysregulation happening in prefrontal cortex and amygdala, and there will be glutamate and GABA imbalance. So one thing is glutamate, if you know, it is an excitatory neurotransmitter, and GABA is an inhibitory neurotransmitter. So if there is an imbalance between, if you say glutamate has increased and if there is decrease in GABA, okay, if there is decrease in GABA and glutamate increase, there will be excitation and we will have these kind of anxious responses. So coming to the specific disorders, the first one is panic disorder. So panic disorder is defined as, it is a sudden onset. It is a sudden onset with no clear stressors. That is very important. Sudden onset with no clear precipitating factors. Okay, no clear precipitating factors, and the patient will have increased autonomic arousal with gastrointestinal, CNS or muscular reactions, whereby patient will have intense apprehension, fearfulness, terror associated with feeling of impending doom. This is very important. What does this mean? Feeling of impending doom. This means that something bad is going to happen. Okay, that is known as feeling of impending doom, and it lasts for it's very short duration, less than 30 minutes, and even after the episode, the patient will have an anticipatory anxiety. What does this mean? Anticipatory anxiety. Anticipatory anxiety means the patient will always have anticipation that whether the anxiety attacks will occur again and again, and usually the patient will present to emergency department with chest pain, choking sensation, breathlessness and hyperventilation episodes. As I told, there is no clear precipitating or triggering factors. And the clinical features, for better understanding, we can divide it as physical and psychological. It's very easy. So physical, you can tell all your autonomic arousal symptoms plus your chest pain like hyperventilation, choking sensation and CNS symptoms like feeling dizzy and lightheadedness, and some gastrointestinal symptoms like nausea or abdominal discomfort. And psychological symptoms you should remember very importantly is this feeling of impending doom. Also the patient has significant fear of death with, I explained, anticipatory anxiety and loss of control or going mad. Many times patient will tell this same thing, and sometimes the patient will have depersonalization and derealization experiences. So what does this depersonalization and derealization means? Depersonalization means detachment from one's own body. Detachment from one's own body. This is depersonalization. Derealization means again detachment from the surroundings. Detachment from surroundings. Okay. So the classical, there is a detachment happening between our body, that is personalization, and detachment from the surroundings, which is known as derealization. And very important thing is, in many of the MCQs, it is written as the patient will feel like as if phenomena, as if something is going to happen, as if phenomena. So coming to panic disorder, I already told this is just summary. Unexpected panic attacks, phobic avoidance, worry about panic disorders, and the anticipatory anxiety. So coming to the next slide. So the mean age is nearly 25 years. Definitely see female to male ratio. Female has 2 to 3 times more than males. And genetic evidence, it is noted that 50 to 20% in first degree relatives. Okay, so whenever a patient comes to you in casualty with the clinical features as I described, the differential diagnosis you should think is myocardial infarction, angina, mitral valve prolapse, asthma, pulmonary embolism, pheochromocytoma, carcinoid, hypoglycemia, hypothyroidism, anemia. Because these all presents like increased autonomic arousal with palpitations, talking sensations and other things. So investigations, very important thing is that whenever a patient presents with panic disorder, this is a diagnosis of exclusion because you have to rule out all the above foresaid causes. So for that we have to do basic investigations like to rule out all organic etiology. You have to do a complete blood count, okay, which have his hemoglobin, his peripheral smear, to rule out anemia or any cardiac disorders, complete blood count, ECG and echo, and also investigations like liver function test and renal function test. You should rule out everything and it is a diagnosis of exclusion. So management is very simple. So we have pharmacological and non-pharmacological management. As in every psychiatric disorders, we have two types of management. So in pharmacological management, the drug of choice is selective serotonin reuptake inhibitors. I told you there is some serotonin dysregulation happening. So what does these drugs do? So if this is the presynaptic area, so this is our serotonin. These drugs, what will happen is that after giving, this is a reuptake inhibitor. Okay, usually the serotonin will have a reuptake action. Okay, it will not stay in the postsynaptic area for long time. So this will inhibit, our SSRIs will inhibit this, thereby increasing serotonin. Okay, that is very important. So this is SSRI. So what are the prototype SSRIs? Escitalopram, fluoxetine and paroxetine. Okay, and other serotonin modulators like venlafaxine. What is venlafaxine? Venlafaxine is serotonin norepinephrine reuptake inhibitor, very important. So this is SNRI. So very simple. Instead of both, it will increase both serotonin and norepinephrine. So what is buspirone? Buspirone is an anti-anxiety. It is an anti-anxiety drug. Okay, it is basically 5-HT1A antagonist. Okay, and what is clomipramine? Clomipramine is a tricyclic antidepressant. So at least I wanted you to remember, there is pharmacological management and the drug of choice is selective serotonin reuptake inhibitors and some other modalities. And non-pharmacological management is cognitive behavior therapy, systemic desensitization and exposure response prevention. That is, this cognitive behavior therapy, what we do is, I will just explain. So always your thoughts, emotions and behavior go hand in hand. So we will try to correct this circle by doing counseling. This is cognitive behavioral therapy. Systematic desensitization, because if the patient is having some fearful responses, for some example, in certain kind of phobic diseases, the patient will have some certain phobia towards certain things, like certain animals. So we will do systematically, we will desensitize the patients. For example, initially the patient will be shown the diagram, then we will expose them to the real scenarios. That is systematic desensitization. We will build upon a hierarchy and we will do. In exposure response prevention, also we will try the patient to do the exposure. If a patient is having fearfulness in going out, we will try them to go outside and then we will try to decrease their anxiety by doing counseling. This is exposure response prevention. Okay, so what is the next concept is phobia. What is phobia? Phobia means a persistent, irrational fear for specific object or situation. So please note friends, the difference between the panic disorder and phobia is that in phobia, there will be a specific stimulus and then the patient will have arousal symptoms. This is phobia. But in panic disorder, there will be no triggering factors. No triggering factors. This is what? Panic disorder. So this is compelling desire to avoid it. That means the patient will have an avoidance behavior. If the patient will have any certain phobia, the patient will have strict avoidance to that, avoidance of the stimulus or situation. So here, if you see summary, the patient will have phobic avoidance and behavioral change. That is the important characteristics is this avoidance. Okay, with autonomic arousal. Two things I wanted to remember. And very importantly, the types of phobia I can tell, you should remember. One is agoraphobia. Agoraphobia, it's there is a misnomer among students. Many people think that agoraphobia is the fear of, closed spaces. But actually it is not. Yes, it is a part of that, but actually it is not. Agoraphobia really means it is the fear of open spaces, crowds, or a place from where easy escape is not possible. That is, the patient will have fear of going to a crowd or to an open places where the escape is difficult. Yes, it can be fear of closed spaces also, but that is not the exact definition of agoraphobia. So exact definition you are clear now, right? Yeah. So coming to other one disorder is social phobia. Social phobia is that here the person will have phobic avoidance to situations in small groups leading to avoidance of social situations, and it happens in adolescence. So here basically what happens, the example is that a patient will not be going to a public situations where he wants to deliver a public speech or something like that. So he himself has an intense fear that he will have a fear of scrutiny by other people, his co-peers. Okay, so and mostly as we can see, this social phobia is seen in adolescent kids. And very important thing is that because of this social phobia, patient will have strict avoidance to the certain situations, and that is one of the causes for what? School refusal. There are other specific isolated phobias like phobias which is restricted to specific situations, animals, heights, darkness or closed spaces. Okay, so coming to our third topic and generalized anxiety disorder. So generalized anxiety disorder is very easy. In generalized anxiety disorder, the patient will have a free floating anxiety all the time. So he is mostly anxious about almost of everything and he will have excessive worries. Okay, and there is no clear precipitating or triggering factor. That's why the anxiety is there all the time. It is freely floating inside the mind. So the patient will have significant difficulties in his occupational and in his social relationship. So if you take this summary of the GAD, so if you can see, definitely the patient will have decreased concentration. There will be decreased sleep, irritability and other autonomic arousal. And one important thing that I can tell you is that in any anxiety spectrum disorders, the clinical features are almost the same, but only one thing is that the trigger will be different, right? In phobia there will be a trigger, but in panic disorder there is no trigger, and in generalized anxiety disorder there is a free floating anxiety happening all the time. And the clinical features is almost I told, it's the same in all anxiety disorders where the patient will have autonomic arousal, palpitation, epigastric discomfort, right? And it's almost equal. Generalized anxiety disorder is almost equal in male to female. Definitely females are more prone. And one important thing you should remember again is that for all anxiety disorders, the treatment is nearly the same. That is what I have described in panic disorder. We have two types of treatment, pharmacological and non-pharmacological. And in pharmacological, SSRIs are the mainstays, and in non-pharmacological, yes, CBT is the mainstay. Let's quickly revise this topic by doing some of the MCQs. This agoraphobia is often seen in patients with panic disorder. Okay, this was the previous repeat MCQ from your all India entrance examination, right? So this MCQ, it's a clinical scenario. Let's try to dissect it out. A 50-year-old male feels uncomfortable in using lift, being in crowded places and traveling alone. The most appropriate line of treatment is what? What is the diagnosis? Yes, the diagnosis here, I can say it is agoraphobia. And yeah, in agoraphobia, always please note that gold standard treatment is CBT. Okay, is CBT. So this question you can, what are the one counseling that I have already told that name? Exposure, response, prevention, okay, and relaxation therapy. So the answer here goes to exposure, response, prevention, right? Coming to MCQ 3. A feeling of detachment from own body and sense of unreality is called. What is that called? I told no, detachment from our own body. This means personalization, depersonalization. What is derealization? Derealization means detachment from the surroundings. Which of the following is the most common psychiatric disorder? Very important. So most common psychiatric disorder is anxiety disorders. This is very controversial, I will tell you, because the most common psychiatric disorder, many will be thinking it is depression. Yes, I can tell you, because anxiety disorders is a spectrum of disorders which encompasses 3 or 4 symptoms, 3 or 4 disorders. So anxiety disorder as a spectrum is the most common. But if you take individually, which is the most common, it is depression. Clear? It is depression. But here our answer is anxiety disorders. Coming to our last MCQ. A patient comes to emergency and feeling of impending doom, intense घबराहट. घबराहट is a Hindi word because this was an AIMS repeat question. घबराहट means intense fearfulness or feeling that I may die, and palpitations. All of the following investigation should be done in emergencies to find out the cause of anxiety. Expect. Yes, I told anxiety, like panic disorder is a diagnosis of exclusion. So the diagnosis here is panic disorder. It's very easy. So definitely we will do glucose levels to decrease to rule out hypoglycemia, and ECG and thyroid function test. Yes, because hyperthyroidism is differential diagnosis. But liver function test, yes, it is warranted, but not in emergencies. That is very important question. This was actually again a controversial question happened in the AIMS. Okay, it was a previous AIMS question. So the idea to convey is that you should always go for emergency investigations, and the diagnosis of a panic disorder is diagnosis of exclusion. I think the anxiety disorders was a good theme for discussion because it is one of the most common disorder that even the students and the patients encounter in our day-to-day life. I think now you are much more clear, right? Yes. So that's it for the time being. So let's meet in another topics. Thank you, students.
Docemy.